welcome to Medical Dialogues, your daily dose of health and medical news. I'm Mr. Zaman, and here is what I bring to you all from the world of medicine. The growing demand for such surgical care, many clinicians, including anesthesia care teams, and their risk factors on patient safety. A new study appeared in JAMA Surgery from a team at the University of Michigan, which examined if the number of overlapping procedures managed by the anesthesiologist increases the risk of death or complications after surgery. Using data from the multi-center perioperative outcomes group electronic health record registry, the team investigated surgical procedures that involved an anesthesiologist directing a CRNA on or an anesthesiology resident. This anesthesia care team model is the most common model used to deliver anesthesia in the United States, focusing their analysis on cases with CRNA involvement and minimal anesthesiology resident involvement. They identified patients with similar demographics and health statuses who underwent surgical cases of various types, including general, gynecologic, neurologic, otolaryngologic, orthopedic, urologic, and vascular procedures. For each patient, they calculated the average number of concurrent surgeries that were managed by that patient's anesthesiologist during the patient's procedure. They then compared instances where the anesthesiologist was directing one between 1 to 2, 2 to 3, or 3 to 4 cases at a time. Overall, 5.19% of cases resulted in some form of post-surgical complication, that is 30-day mortality or one of 6 major surgical morbidities: cardiac, respiratory, gastrointestinal, urinary, bleeding, and infectious complications. When compared to an anesthesiologist directing anesthesia for 1 to 2 overlapping surgeries, directing anesthesia for 2 to 3 or 3 to 4 overlapping surgeries led to an increase in the rate of morbidity and mortality. Instances where the anesthesiologist was directing 3 to 4 surgeries at a time had a complication rate of 5.75%, a 14% increase compared to the complication rate of 5.06% for 1 to 2 overlapping surgeries. Researchers concluded that anesthesiologists have been saying for a long time that covering 4 rooms is possible but should be reserved for situations where they think it is safe. Increasing overlapping responsibilities may have some potential downsides that balance the advantages of potential cost savings and access to care. People with endometriosis who are at greater risk of cardiovascular diseases such as heart attack, high blood pressure, and high cholesterol. A large prospective study found that women with endometriosis may have a higher risk of stroke compared to women without the chronic inflammatory condition, according to the research published in Stroke, the peer-reviewed flagship journal of the American Stroke Association, a division of the American Heart Association. Study enrolled the Nurses' Health Study 2. The analysis involved 112,056 women who were nurses between the ages of 25 and 42 years old from 14 US states at the start of the study in 1989. The current study ended in 2017. A laparoscopy, that is surgical procedure in which a fiber optic instrument is inserted through the abdominal wall to view the organs in the abdomen or to permit a surgical procedure, was used to make the diagnosis of endometriosis. Endometriosis was reported in 5,244 women, and most of the participants, that is 93%, including those diagnosed with endometriosis, were white women. Additionally, researchers investigated if the link between endometriosis and risk of stroke could be explained by other mediating factors such as high blood pressure, high cholesterol, hysterectomy, that is removal of the uterus, oophorectomy, that is removal of the ovaries, and postmenopausal hormone therapy. During the 28 years of follow-up, including medical record confirmations, researchers documented 893 strokes. The analysis found that women with endometriosis had a 34% greater risk of stroke compared to those without the condition. The largest proportion of the stroke risk associated with endometriosis was linked to hysterectomy and or to oophorectomy, that is 39%, and postmenopausal hormone therapy, 16%. No significant differences were seen in the relationship between endometriosis and stroke across multiple factors such as age, infertility history, body mass index, or menopausal status. There are circumstances when a hysterectomy or an oophorectomy is the best choice for a woman. However, the authors also need to make sure that patients are aware of the potential health risks associated with these procedures. online obesity programs and how successful they are in weight loss. Previous trials of behavioral obesity treatment delivered in the primary care setting have typically involved intensive researcher involvement to deliver treatment and/or maintain participants' engagement with the research study. The current study is one of the first that a fully automated obesity treatment program has been tested pragmatically in a large primary care network with clinicians responsible for identifying patients, providing the program, and supporting its use. As part of routine primary care, healthcare providers and 16 nurse care managers offered a no-cost online obesity treatment program named RX Weight Loss or RXWL to 1,765 patients at the Rhode Island Primary Care Physicians Corp, a primary care practice organization which includes approximately 60 practices with 100 physicians. Eligible patients were aged 18 to 75 years old with a body mass index of greater than or equal to 25 kg per square meter and internet access. The program included 12 weekly online sessions, a self-monitoring program, and automated feedback. The average 12-week weight loss was 5.1%. Researchers note that most e-health obesity treatment report average weight losses of 2.5% initial body weight at 12 or 24 weeks. Patients who reported their weight on all 12 weeks achieved an estimated weight loss of 7.2% compared to 3.4% in those submitting less frequently. Patients who accessed all 12 video lessons achieved an estimated weight loss of 8% compared to 4.2% for patients who accessed fewer lessons. Neither BMI, sex, nor identification with a racial or ethnic minority group was associated with these measures of engagement, but age was associated with a greater number of lessons viewed. The study concluded that a highly innovative model of behavioral weight management that potentially addresses several barriers encountered in primary care and must be considered. How smell is affected because of head injury. Otolaryngology, head and neck surgery, investigated the associations of prior head injury, number of prior head injuries, and head injury severity with subjective and psychophysical olfactory function in older adults and to examine concordance between subjective and objective olfactory function among individuals with and without head injury. The prospective cohort study included 5,951 participants who attended atherosclerosis risk in communities or ARIC. Data analysis was performed between November 2021 and May 2022. Self-reported subjective olfactory dysfunction was assessed by the questions: do you suffer from smell loss or a significantly decreased sense of smell? The total of 5,951 participants were female, 1,356 were of black race, and 1,666 had a history of head injury. Participants with prior head injury were more likely than individuals without head injury to report subjective olfactory dysfunction, that is 24% versus 20%, and have objective anosmia, that is 15% versus 13%, but had lower concordance between subjective and objective assessment, 72% versus 77%. In logistic regression models adjusted for socio-demographics and medial comorbidities, including cognitive status, participants with a history of prior head injury, particularly individuals with 2 or more prior head injuries and more severe head injuries, were more likely to self-report subjective olfactory dysfunction and were more likely to be found to have objective anosmia compared with participants with no history of head injury. Findings of this cohort study provides evidence supporting the association between head injury and olfactory dysfunction, particularly among individuals who experienced multiple prior head injuries and among individuals with more severe head injury. The findings also suggest that individuals with prior head injury were more likely to both under self-report and over self-report deficits compared with objective olfactory testing. Therefore, it may be more important to consider objective olfactory testing in this patient population. That's all for today. Stay tuned to Medical Dialogues for latest updates.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.